All right, welcome. Thank you all so much for joining us. Got a few more folks coming in here. Well, welcome. So glad you all could join us, and we're so delighted that this webinar will be recorded for viewing at future points in time. My name is Todd Jensen. I'm a faculty member in the School of Social Work at the University of North Carolina at Chapel Hill. I'm also the lead for the Family Measurement Node in the Life Course Intervention Research Network. And we're delighted to welcome you all to the 5th webinar in our series, exploring the central role that families play in health and well-being and how we can design interventions that support families to improve their health trajectories across the lifespan. And up to this point, previous webinars have really explored the importance and roles of families in health interventions and have discussed some of the challenges, including how to measure effects on family health over time. And this webinar is really going to zoom in on this piece, how we can explore family health measurement, and we'll be highlighting a specific tool that could be used by life course intervention researchers. So at this point, I'd love to briefly introduce our wonderful speakers. We have 3 of them. So first we have Dr. Alison Crandall, who's an assistant professor in the Department of Public Health at Brigham Young University. Dr. Crandall received her bachelor's degree in community health education from BYU, her MPH from Loma Linda University, and her PhD from Johns Hopkins Bloomberg School of Public Health. Prior to her PhD, she worked for 8 years in domestic and international settings on various public health programs focused on strengthening individual health through family interventions. Her primary research interests include family health measurement, understanding how childhood experiences affect lifelong health, and mental health in adolescents and adults. She teaches undergraduate and graduate classes in program planning, evaluation, and family health. She currently serves as the BYU MPH Program Director. Next, we have Dr. Jerica Berge, who is a tenured professor and vice chair for research in the Department of Family Medicine and Community Health at the University of Minnesota Medical School. Dr. Berge is both a researcher and behavioral medicine clinician. She's a licensed mental health therapist and supervisor who specializes in complementary and integrative healthcare and community-based partnerships to address family health issues. Her NIH research agenda focuses broadly on child and family whole person health promotion across the life course, with a particular focus on social and structural determinants of health. She's the director of the Healthy Eating and Activity Across the Life Course Center, or HEAL Center, and the co-director of the Community and Collaborations Core in the Clinical and Translational Science Institute at the University of Minnesota Medical School. And next, we have Nomi Weiss-Laxer, who is a research assistant professor in the Department of Orthopedics and Family Medicine at the University at Buffalo, the State University of New York. She received her PhD from the Johns Hopkins Bloomberg School of Public Health and her MPH from Brown University. She served as a research coordinator for the Family Health Technical Working Group, supported by the Maternal and Child Health Bureau. Her Life Course Intervention Research Network pilot study assesses the feasibility, acceptability, and utility of using a brief measure of family health, the 10-item family health scale, in primary care pediatrics. So it's now my pleasure to turn the time over to our wonderful presenters.
Thank you for the introduction, and I'm going to start us off here. So we're delighted to be presenting with all of you today about our work in the area of family and health. We'll be tag teaming this presentation, and I'll start us off, and then we'll move to Nomi and then Ali, and then I'll wrap us up. So as you heard a little bit about us, I'm going to start us off on this slide here, where it shows a little bit of the context of our work and how we came together, what we've been up to, and where we are heading in understanding family health across the life course. This figure depicts several different key things about our work that I'll walk us through. First, you can see that we are very multidisciplinary. So we represent public health, mental health, family medicine, family social science, psychology, different approaches and methodologies. Geographically, we are diverse from the representation in the East Coast, the Midwest, and the West. We are also a mix of clinicians. So we have MDs and PhD licensed mental health providers, family therapists, researchers, and educators. And so this has really brought a wonderful mix to how we approach our work. What first brought the majority of us together was our work on developing a family health measure. So this was started with a grant through the Maternal and Child Health Bureau. the Maternal and Child Health Measurement Resource Network. So we're going to present a lot of our work in that area today and what has become of that measure. So I will move on from that one to where we have also really been together. So from that, we really started to think about how we can measure, monitor, and then think in a larger sense theoretically, and then testing all of this work around family health. So we did many presentations across this time that we've been together at conferences such as the National Council on Family Relations, Collaborative Family Healthcare Association, and others. Simultaneously, we all knew and heard about the Life Course Intervention Research Network and got involved there. So we represent different nodes. Some of us are in the Families and Health node, some are in the Family Measurement node. And so really have been able to expand our own network as a group to others across the nation doing this work, which has been really revitalizing and helping us to think even more and push us more in the way we're thinking about this. Along the way, we also saw the need to not only measure and monitor family health, but contribute to the theory and understanding of family health. So we've been really working on a conceptual model of understanding family health, family functioning, family resilience, flourishing, and overall family well-being and how they work together and helping us understand more about family health. And simultaneously along the way, we've also been publishing, receiving grants, and implementing studies to help us learn more about family health and how it works through multiple ways. So you'll hear about some of the validation studies we've done with our measures. We've moved into doing cross-sectional longitudinal studies, both observational studies and moving into clinical trials and looking into conceptual models and how to test those. And so we're really kind of moving along in this cyclical way in which we're working around the work in family and family health. So with that as an overview as a contextual platform, we now want to launch into our focus of the presentation today, which is really helping to describe what we've done in the area of family health measurement. So the construction, the validation, the testing, and application of our family health measure.
Thank you, Jerica, for getting us started. So as we know, and of course, this is not new to this group, in the audience, families lay a critical social foundation for health and health development across the life course. And families really serve as that crucial link between individual health and community resources and policies really that can impact health, as well as providing skills and patterns of behavior across the life course. So we know that over time, families are critically important, yet the measurement of families has been something that we've really wanted to focus on in this interdisciplinary work that Jerica just mentioned. Next slide, please, Ali. So part of this work was a paper that we put out, me and Ali, as well as two other co-authors, put out talking about the role that public health can play in moving families to the forefront of public health responses. Both by, and really we, in this paper, among 4 different main recommendations, we recommended that public health monitor family health on at a population level. So in national surveys, in programs that are child and family serving, to measure impacts of those programs, and also to really help push the US to set national goals that are family focused and that have family level variables that they're studying over time. To create those recommendations, we did start with a scan of surveys currently out there, and the National Survey for Children's Health was really the exception in terms of having family level variables being studied, as opposed to the vast majority of other national surveys, which tend to focus on individual level health. The next slide, please. So in thinking about, what was missing in terms of practice and research, it's really that monitoring piece. So we really this work has been to bring together a variety of lenses that Jerica mentioned, and to really think about what types of measures we can use to look at impacts of programs and to look at those malleable factors at the family level that can push programs along. So that was the focus of particularly that beginning work with the Maternal and Child Health Bureau and measurement. So I want to sort of launch into that work there. So the next slide provides, so the first step of that measurement work was to come together around the definition of what was family health. And so although we had, there are many measures that look at aspects of family health and functioning, we really wanted to come up with a definition that could be used to drive this measurement work. So this was the definition that we landed upon. So family health being a resource at the level of a family unit that develops from the intersection of health of each family member, their interactions and capacities, as well as the family's physical, social, emotional, and economic and medical resources. So using that definition as the launch point, we developed a scale, and you'll see that testing and validation in the next slide. But thinking of, yes, thank you. That culled from a variety of nationally validated surveys to get at that core definition that looks at family health as not just the individual member's health, but really looks at a group level measurement. So this slide depicts some of that work, the history, the trajectory of some of that work with development, validation, and testing. And Ali will take it away in terms of how that work has been applied. But we started with 2 nationally representative samples to create that testing, and the ultimate product of this work was both a long and a short version of the family health scale, which is now being used in both intervention work, observational work, as well as practically in clinic settings. Now I will pass it over to Ali.
Thanks, Nomi. So I'll just go over, Nomi briefly mentioned that we developed this long and short form of family health. And so I wanted to go over the actual sort of methods and results of that work. So we started with, well, it took a while to get down to a number of items that we felt was tangible. We wanted a scale that was around 20 to 40 items for the long form. And of course, it takes a lot of iterations to get to that point. I think we started with 70 plus items, and eventually we whittled it down in this final sample of a 1,050 to a 32 item scale. We recruited this panel through Qualtrics, which is an online survey platform. And we used a quota sampling approach because we wanted to loosely match the demographics of families in the United States. So we wanted to make sure we had a variety of family structures, socioeconomic strata, and racial and ethnic groups. And then each participant completed a survey that, of course, had the family health scale. We call that the FHS, those items. And then we also used some measures of family health, family functioning, and other family context measures, so we could look at the construct validity. And we did some exploratory and confirmatory factor analysis in an SEM framework using M+. And we did, because if you use the same sample, then the CFA will basically automatically confirm the EFA. So we took a random 1/3 split sample for the EFA and then the other 2/3 for the CFA to confirm the EFA results. Then to establish clinical cutoffs on the short form, we brought in a second sample that we recruited through Amazon Mechanical Turk. That was of 501 adults. So first of all, just the results of from that sample of 1,050 people. We ended up with a 32 item long form measure of the family health scale that had 4 dimensions. And each item was assessed on a 5-point Likert scale, ranging from strongly agree to strongly disagree, with higher scores indicating better family health. So some items have to be reverse coded so that all the higher scores will be better family health. So the 4 dimensions are these family social and emotional health processes, which really gets at things relating to connection, communication, satisfaction. This was a dimension of the family health scale that we thought would be highly correlated with family functioning, as there's quite a bit of overlap there. Family healthy lifestyle, which looks at internal processes of the family that look at healthy habits and choices. So eating meals together, exercising, encouraging each other to follow medical recommendations. And we also have the family health resources subscale. This one's kind of a broad category. It hits on material resources, so food, shelter, and money. But there's also this internal resources component of the individual member health of each family member, because that affects the family work-family balance, the family's help-seeking efficacy. And then the final subscale is the family external social supports. So just like as individuals, sometimes we have needs that go beyond ourselves and we need others around us to support it. Families are the same way. And so when needs go beyond what the family can do, does the family have people they can turn to as social supports that are available to them? So sort of their social capital. Then from those 32 items, we pulled 10 items from it that comprise the short form scale. So the short form is a unidimensional measure of family health that's pulling from each of those 4 subscales. And so these are the 10 items that make up the short form. And often when we do surveys, we don't have room for all the items. And so we rely on short form measures. So we wanted to make sure we had the long form where we could look at different dimensions of family health, and then also the short form too, for this unidimensional measure. And as we'll talk about a little bit more, we're hoping to use it also as a clinical measure. I will note that 3 of these items need to be reverse coded, and this can sometimes maybe be more problematic in a clinical setting. In survey research, it's really best practice that you have some items that have to be reverse coded. It helps to make sure your participants are really reading the items and paying attention to your survey. But in clinical, there may be times where you might think, we do not trust doctors and health professionals, should we reword that so it's in the same direction as others? But again, we just created it primarily first off as a survey. And so that's the rationale for some items needing to be reverse coded. Looking at the reliability and validity, all of the items had Chrome box alphas, which are above 0.8. And there's some limitations to the Chrome box alpha. And so I'll also mention that we had adequate or good model fit in SEM using the RMSEA and the CFI. When it came to looking at the construct validity, we expected that we would have pretty high correlations between the family social emotional health processes and the FAD scale, which is a measure of family functioning. And we did. That's a 0.86, which indicates a high correlation. So that helped us to feel more confident with the validity of the scale. We also expected that the family health climate score, which looks at some nutrition and physical health behaviors of the family, that it would be highly correlated, especially with family healthy lifestyle. And it was. So that gave us we were on the right track with this measure. Then with that short form, we wanted to see if we could establish clinical cutoffs. So what we did is we took the 10 item short form, and each item's on a 5-point Likert scale, and we dichotomized it so where they agreed or strongly agreed with an item, that was coded as a 1, and then if lower, so scores below that were coded as 0. And then we could add up all of the items, so it could range from 0 to 10. And with establishing these cutoffs, we included both our sample of 1,050 adults that we recruited through Qualtrics and also the MTurk sample of 500. So we had 2 samples that we could look at that both included this family health scale. And then they also included the PHQ-9, which is a measure of depressive symptoms. For the family health, we looked at the 2 samples and together established cutoffs of scores below 6 was poor family health, 6 to 8 was moderate, and 9 to 10 was excellent. And that was based on the distributions of those 2 samples with the FHS. And what we found here was that those with moderate family health compared to those with poor family health, they had 72% lower odds of having moderate to severe depressive symptoms. And somebody from a family with excellent family health compared to poor family health, they had 93% lower odds of depressive symptoms. So at least with depression, there was a pretty high correlation of family health being protective against depressive symptoms in individuals. And here we did add the samples as controls, and they were not statistically significant. The next step we took on our validation is with any family measure. Really, in the prior studies, only one person had answered these questions about family health. So it's not one person's perception of family health. But for it to be a real family measure, we need multiple reporters in the same family. And so in the family health exploration study, we were able to get married and cohabitating couples. And these couples all were parents with a child between 3 to 13 years of age. And we asked both members of the couple to report on their family health. And I don't have the full results here, but this is just a citation of that paper. But what we did find is that the responses, it worked really well. They're highly correlated, both partners' responses. And the best models were when we combine responses from both partners to get the overall measure of family health. Some researchers around the world have started translating the scale into other languages, and there are a few publications now on the validation of these scales in Chinese, Thai, and Turkish. And we'll mention later some other languages where the validation of the scale is ongoing. And I'm going to turn it back to Nomi to talk about some of the qualitative work she's done with the scale validation.
Thank you, Allie. So this, I wanted to talk about the LCIRN supported pilot study that I've led, and with my two of my co-author mentors here as well. The goal of this is really to refine and adapt the short version of the family health scale to primary care pediatrics. So next slide. And the aims was to get perspectives from both staff and providers within pediatric primary care, as well as parents and caregivers bringing children to well visits. So what we did is recruit parents from pediatrician offices in the waiting room, so sitting in waiting rooms, and the child could be any age. We asked a series of closed and open-ended questions, basic demographics. We administered the family health short version of the scale, and then asked parents follow-up questions. How long did it take them? Was anything confusing? Anything else you want us to know? That sort of thing. The next slide, please. And this particular population, so we surveyed 2 safety net clinics within an urban area. We had 92% were mothers, average age 34 years old. A pretty good distribution in terms of age of the child being brought to their doctor's office that day. So a third were infants, 44%, 2 to 11, and then a quarter were adolescents. The majority of the parents or caregivers identified as Black African American. They reported an average time to complete the survey as 8.5 minutes. And most said that was just right in terms of length, that it was understandable, and that the questions did not make them feel uncomfortable. And we asked them about frequency they thought would be, feasible to complete this survey, and they said about once a year, which maps some of our provider feedback. And then we did ask the question at the end of the scale, if they would like to speak with a provider that day about any of the topics that they answered related to family health. And 40% said that they would like that in the form of a referral. And 30% said, in the form of getting follow-up care from the clinic. And then the other piece of this refinement and testing of feasibility and utility of the scale in pediatrics were semi-structured interviews with providers and staff at those same 2 pediatric practices. Those interviews we conducted over Zoom. They took on average 45 to 60 minutes. And here you have listed the types of providers and staff members that we were able to interview. So pediatricians, they had one social worker that was covering both clinics, as well as administrators, front desk staff, members who are often the first line of, administering surveys, just describing the intent of each screener or survey that parents receive, and also, administering that survey throughout the practice of making sure that the responses get back and get communicated to providers. So what we found from those interviews, so preliminary findings suggest that basic household information is being collected about families. Typically that's recorded in the social history note in the chart. Sometimes who's part of the childcare team is assessed, but that's typically only assessed, most systematically assessed during the newborn phase with new parent visits. And then in terms of family relationships, communication, dynamics, screens for safety, those typically happen at that newborn visit, as well as the first and sometimes follow-up adolescent visits. It didn't seem like those relationships were being systematically assessed at every single well visit. Providers and staff also had many suggestions for us in terms of reducing the number of items. So in these two practices, there is a social determinants of health screener that asks about some of those material needs. Most providers found the last several questions on the short scale to be redundant with that other scale that's being offered for families. Many of them, however, thought the first 6 were novel items that were not being currently asked of every single family, and thought that there would be value. Another finding that was expressed by most of our providers, so the pediatricians and the social worker particularly, were that some of these questions would lead to a specific referral. So if someone answered, for example, the item about not feeling safe within a family, that could lead to additional follow-up questions and maybe a referral for violence prevention or maybe even legal aid services. However, others were more of conversation starters. So to talk about, the role of the family health caregiving system in the health of the child and child development over the years, but also the importance of family health for promoting, health of multiple family members. And then a recurring theme that came up was the importance of establishing that trusting relationship between parents, caregivers, and their providers, and starting with that first hello from the front desk staff and establishing a climate in which families felt like, they could be open and honest about changes within their household, changes within the caregiving and childcare structures and dynamics within their families. That being critically important also in kind of letting families know that this was an important piece of the health and development of their children. The next slide. So here are some quotes from providers. The first one in blue is really talking about, the importance of creating that climate, that welcoming environment, so that parents aren't shutting down and just thinking about going to the pediatrician as a way to get immunizations, and also to help lift some of the stigma and shame that might be felt about answering questions around household dynamics. This other provider emphasized the importance of relational health, both for health and development of children, but as well as the relationships that are established between pediatricians, doctors, clinics, and parents. So I'll read the second part of this. So I just appreciate that you're looking at these things, meaning the family health scale and related topics, and trying to improve and maybe change the idea that you don't tell your business to people, and re-educating that it's okay, that there is no judgment. These are key things and important things that we really need to look at and address. So again, creating an environment that reduces judgment and hopefully any sort of shame that a parent or caregiver might feel answering these types of questions. The next slide. So thinking about next steps of where to take this research, we heard loud and clear from providers and staff that it was very important to explain to parents and caregivers why these questions were being asked, and also potential next steps of what to do with scores or answers to questions. So that it might be that, we determine that in certain pediatric practices, it's very appropriate to use this measure because there are, a host of services and community linkages that can be made to address these topics. And then maybe in other practices, it's less appropriate because those services and linkages don't exist. So the providers really felt that it was necessary to have very clear follow-up steps to any screener that was administered related to family health. So this provider says, if I'm asking these questions, I'd like to have something that's a bit more proactive, a little more engaged than just asking the questions. And if that means bringing in support staff, which is probably the best way. So I'm really thinking about, maybe, so some suggestions that we received were having care coordinators, social work staff, mental health providers, being the ones that get brought in if they're as a follow-up to some of the answers to these questions. And then, so for next steps in terms of this research overall, it does appear that, there is room to improve in terms of asking about family health issues within pediatrics, certainly systematically asking in the same ways, right? So that we have the ability to monitor progress over time. And that having a scale like the family health scale could be a step towards bringing family topics, family dynamics front and center within that care, which we know has implications for life course health. And we'd be able to monitor that if we had these surveys being administered. And that, the incorporation of the short form can be seen really as an initial assessment and then conversation opener to talk about dynamics that are happening in the family, 2 and 3 generational topics and dynamics over time. And that this might also lead to the development and use of educational resources and programs that highlight the importance of relational health, both within the family and among families and their providers, that could build these capacities that we think really matter in years to come.
All right, so now we're going to talk just a little bit about the applications of the scale that we've used a little bit in research. So I'll talk first about some things that we've done in my lab, and Jerica will share a study that she's working on with her research group. So first of all, with a student, we looked at some of the correlates of family health. So we looked at a variety of physical and mental and socioeconomic factors just to get an understanding of how they related to family health. This was cross-sectional work. It was actually using that same sample that we validated the scale with, but we had some other constructs in there that we could look at. And some interesting things was, you'll notice here that depression is negatively correlated or associated with all of the family health domains. And what really stands out to me is how highly associated it is with the family health resources. So this is the material resources, and then the family's also their sort of help seeking efficacy, coping, and work family balance. So depression and that, which one causes the other, it's probably a little bit cyclical, but that was something that stood out to us through that work. Income is very modestly associated with family health, but education is not. And that's important, that it doesn't matter the educational status of the adults in the family, but the family can be healthy throughout. And income might have some modest correlations, but it's not that strong. Other items, age, interestingly enough, as people age, they reported slightly lower family health on 3 of the 4 domains. And we've seen some mixed results with that across different studies there. Another thing we looked at is adverse and positive childhood experiences. So these are cumulative measures of either advantage or adversity in childhood. And a lot of those measures have to do with the family of origin. So an adult's family in childhood, how it affected them. We wanted to see how it affected their report of family health in adulthood. And what we found in the adjusted models was that positive childhood experiences in particular were associated with better family health across all 4 domains. Adverse childhood experiences were only associated with family social emotional health processes and family health resources. And of course, that's a negative association. It's a little bit more modest than PCE. So it seems to be the positive things have a higher perhaps a higher predictability of family health in adulthood, and in the direction that we'd like to see. Some other studies, and I've included these references here, and we'll provide these slides later. And I should mention, I don't know if we've mentioned it before, but the family health scale is publicly available. So if you look up the original study in Frontiers of Public Health under Supplement 2, you'll find the full scale. And that can be used in your research or other work. And so these are some other studies where we've used it. We looked at how COVID-19 was affecting family health during the pandemic, how family health might mitigate the transmission of trauma across generations, family health and social media use, and also overeating are a few of the areas that we've looked at so far.
All right, so I'm going to share a little bit more about other areas where we've taken this family health measure and moved in some more longitudinal and clinical trial work. So the 2 studies you see here on the screen are ones that I lead. The first one is called the Family Matters Longitudinal Cohort Study. So this is a true, epidemiological cohort study with 4 waves of data collection on 1,307 diverse families. And so in the Twin Cities, you may be pretty familiar that we have quite strong diversity, as well as families from immigrant refugee populations. And so this is across the families, we have a really good sense and understanding of different cultures, different household structures, sex gender differences, and single dual households, and multi-generational households. So it's a really nice way to look and see how family health operates over time. And it gives us an opportunity to look at it as an exposure, an outcome variable, mediator, or moderator, and just really get a better understanding of how family health is working. This has now been collected in 2 of the waves, the 2 waves prior to us having the family and health measure. So we're going to be able to really look at some longitudinal outcomes and results here soon. The other one is what we took from our intervention. We developed a program. So our intervention we call Family Matters Program, and it is a clinical trial. And this is with 525 diverse families, also in the Twin Cities, but a different sample than the cohort study. And I should say the ages of the cohort study started at ages 5 to 9 and have now followed them over 5-6 years, usually about 12 months apart. And in our intervention, we also started at an early age of between 5 to 8. And so now are intervening with these different families. And this is really testing 3 arms and a combination of things to really try to understand if we can intervene on child and family health through mixed methods, including mHealth technology, community health workers as the interventionists, and we also use video feedback on real-time behaviors and helping people to understand how their actual behaviors impact the health outcomes that both they at an individual level and at a family level are engaging in. So within these studies necessitated some translation. So as we heard a little bit earlier, we've already had some translation of these measures, and now we've also moved it to Spanish, Hmong, and Somali speaking populations related to the studies that I lead. And then on the next slide, we'll show you a few more that have now also been either ongoing or moving towards finalizing this, but they've looked at different cultures. You'll see here also different types of studies. So moving from just observational to trials, and then also generational studies. So you see here, there's some that are looking at 3-generation studies of families and health. So we really get a better sense of how this scale works in different populations, backgrounds, and study designs. So it's pretty exciting. So now I want to move us into kind of the bigger picture of where we're headed and some of the next steps. And so You've heard that we continue to look for refinement opportunities, especially across settings. So in research, there may be reasons to do the scale in the way in which we've already established it. And in clinical settings, it might make sense that we are going to need to do some refining to change that to make it really fit well as a screener or things like that in primary care and pediatrics and other clinical settings. But continuing to do that as well as across cultures and languages, realizing that that is just an iterative process and that we continue to engage in that. Also adaptation of the family health scale with regards to ages and stages of family life. We're really interested in understanding more about adolescent responders and how they interpret these questions and how they fit for that population especially. And then the opportunity to really look at these trends in family health globally. That's a real strong interest of where we'd like to see next, how this might look and how things might be similar or different for families in different parts of the world. Now, we also know that there's, again, different domains in which this scale will be useful for and helpful for. So I wanted to talk through a little bit the clinical setting and then research and how that might look. And so in the clinical settings, you've heard a little bit about what we're already doing. This is of interest to many of us because many of our appointments also have a clinical component. And so within the clinical setting, we see lots of opportunities in how this may play out from being a screener perhaps at these clinical visits to understanding, training opportunities for our residents and others who are in clinical or practical settings to understand better family health broadly. Also can consider child and family programs more broadly. So whether it's within WIC or county or state level offices that work with families, as well as early child family education programs, even extending into school systems and thinking how this might be useful and relevant for all those different domains. With regards to research, you've heard us say a little bit about this, but really interested in seeing, again, more opportunities to put this into research studies in some of the observational studies that help us get an ability to monitor family health, as well as intervention studies that help us to be able to test and do experiments to find if we're able to actually intervene on family health. The federal national surveys are one that is a goal for us as well, that it becomes kind of a staple or understood an important survey item that needs to be measured and monitored. And then moving again to NIH and other larger other larger grant mechanism and funding agencies, rather, to continue this work. We've also thought a little bit about the education domain. So the importance of not only having clinical domains and other practice sites using this as well as research, but the education piece and how are we going to embed this and really think through making sure that those who are in the next generation coming forward really know how to think about and measure and conceptually also think about family health. And so graduate programs that are around the country thinking the importance of embedding this in the type of training that they receive, especially in those that maybe might be moving into clinical and practical settings, research training programs from postdoc opportunities to others in which they're really learning about these types of abilities to measure family health more broadly. Internships, and then in the clinical realm, I wanted to make sure we mentioned residency programs and others that really teach the next generation of providers who work with families around health. So now we are moving into the time in which we have some opportunity to interact with the rest of you. And we did pose a few ideas to think about for the audience as far as things we're interested in hearing about from all of you as you've listened to us. What are some of the gut reactions you've had about feasibility or acceptability or buy-in of this measure? What might be some of our barriers and opportunities, best practices, and other things like that? So we have some things we'd love to learn from you. At the same time, of course, we are open and interested in hearing other comments or questions that you might have for us. So thank you.
Thank you so much. I'm going to get my reaction emojis out here. A round of applause here for our great presenters. Thank you all so much. This has been such a rich and detailed overview of this construct and this measure. And I love these prompts that you have brought with you. So for all of you joining us today, definitely look at these and feel free to pop into the chat any of your reactions to these, insert any other questions. Even feel free to come off mute if you'd like to let us hear your voice as you share your thoughts or questions. And in any case, as we wait for some of those thoughts to emerge, I'm happy to jump in here as well. And I know Ali and Nomi, I know we've engaged in a number of conversations about these family level constructs. And I would love to hear, thoughts you have about your journey and your process of conceptualizing family health. And as you're kind of going through the jungle of family level constructs, some of which exist and have different names: family resilience, family stress management, family coping, family functioning. Would love to hear anything you'd like to share. I think folks here might also appreciate hearing your thoughts on this. Just that process. What was challenging about that? What helped you get clarity around this distinct construct of family health and how it relates to others?
I'm happy to maybe jump in on that. It's a process that we still, I think, keep working through. But at the time, as we looked at different skills, like some of these skills are better at looking at sort of the roles and responsibilities and tasks that families should accomplish. I kind of see that more in the family functioning area. Family resilience looks so much at the time when families are going through adversity and then what they take from that and the meaning they get from it. Family health, certainly there's some overlap with these areas, but it looks at more of these resources that a family has that may affect its functioning and its health. Sorry, not its health, its resilience over time. And coping is embedded kind of across all of, especially resilience and health. It's embedded a little bit in it. So it's one of the things that we have discussions about all the time, is that we make sure that there's a clear in the field. And I think this is a challenge, whatever field we're in, as we work in family measures, that we really look at the literature to be consistent on how they're defined and which one it is that we really intend to use. That we don't create just the soup of family measures that, depending on which name we like best, we use, but really kind of considering that. So I guess when we conceptualize family health, we're thinking, well, we talk about individual health all the time, but let's build that up to a family dimension. And I'm seeing in the chat, is there a definition of family provided? And I'll pull that back up, but it really looks at, with all these family measures, you have to consider how the family members interact with each other. Now, of course, I'm not finding, here it is, there we go. It's the interactions and capacities of each member. And I think that's consistent across any family scale, is that you have to look at that. And we define it as a resource at the level of the family. When I say this was a huge group, as Nomi mentioned, of people from around the US coming from different fields that helped to provide this definition.
Yeah, no, that's so helpful. That resonates so much with me too, this process of thinking about where a family level construct exists in relation to others. And there's almost this Venn diagramming potential where you use the term overlap. There certainly can be these points of overlap. Sometimes there's these hierarchical dimensions where some dimensions of a construct kind of could be, nestled under a higher order construct, but all those things. And it's just a lot of cognitive work can go into that. And so I'm just expressing some of my respect and admiration for just that pursuing that journey and developing a measure that's tapping into this construct. We've got some things happening in chat here.
I just wanted to point out, so the question about how we define family, like Ali said, really open in terms of administrating of the survey. From that same paper, we did ask that in the Delphi process to define family as well. And I provided that in the chat. It's from the same article.
Oh, great. Thanks for providing that.
And I think your point, Nomi, that maybe started the original chat was just on the scale when someone fills it out. We asked them to think ask the respondent to think or consider who they think their family is. So we don't provide a definition as either one that we just provided in the papers that we've gotten from the work that we've done, but rather let the individual participant decide that. So I think just to clarify, that's what a scale does.
Gotcha. So respondents can say, oh, whoever comes to my mind when I see that word, that's what I'm talking about. Yeah, I think that's fantastic.
Yeah, and usually in most of the surveys we do, we'll ask them at the end after they've answered the questions, did you consider family members who just lived in your household, who lived outside of it, or both in and out of their household, to kind of see if there's any differences in responses by that. So we do try to capture a little bit on who they think their family is, but it's not, I guess, an official part of the skill.
I'm very interested in that. I'd love to see some of your findings on that, actually. Yeah, what comes to folks' mind when they're asked to reflect on that word, family? I'd actually, empirical data on that. I would love to see a large scale data collection effort there just to see what folks say. We have someone here in chat. If I were to select 1 to 3 questions from the family health scale, I would select items 2, 5, and 6. It looks like we might zip over to those items. Now I'm curious which items those are.
Just a second, we'll get there.
Yeah, no problem.
And that answer does resonate with what our pediatric providers and staff said, that if we had to cut down the scale, that they would also focus on the top 6, really, they said. Because again, they had already included a social determinants of health screener for material needs in their clinics. But certainly, so it sounds like, yeah, so safety within the family, staying hopeful, and then trusting providers. Those also were really important for pediatric staff.
Great. Keeping an eye on chat here. I know we just have we have a few minutes left here. Another question that kind of rose to my mind. I know in one of the slides noting, the frontiers of this work and where future work could go in exploring this measure. And there was this idea around potentially examining, maybe even adapting the measure in accordance with the unique dynamics and situations of a family across the life course. And that could reflect, the development of the individuals within the family, right? As if a child or children are growing and getting older and their needs are changing. I'm just curious if any, even if very loose, insights have come up for you all in terms of what those adaptations might look like as you track a family across the life course. Are there certain items that might really come to the foreground at certain time periods and others that might kind of go more into the background? And I realize this maybe isn't something that, given all the work you're doing, have had a lot of time to reflect on, but I'm just curious if anything has kind of come up for you in that regard.
So, Jerica, you go ahead.
I was actually going to say that I thought that the study that you had been involved with, where it looked at some differences by older age and aging populations, was interesting. And so that may be where you're headed with what you were going to say. But to me, that's an area that I think is quite interesting, and trying to understand what family health looks like in an aging population. And that's an area I'm really interested in this going.
And just quickly, I'll say who they think of when they think of the word family. And
right.
How that might be. Yeah, that's so fascinating. But I'll let y'all jump back in.
Yeah, so when we initially created this scale, we wanted a scale that was generic for a variety of family types, including families that didn't have children. And so there could be differences, though, when we start diving into like families with young children, with adolescents, and so on. So we're not there yet exactly. We did one of the studies where we did the couples validation was just of parents with children, in that case that were 3 to 13 at baseline. And we're just initiating a study that's 3 generations where we have a young adult, a parent, and a grandparent. Then we can see how that'll be really interesting to see how they even conceptualize family, if they're all conceptualizing it the same. And then the difference is kind of this generational difference. And then hopefully we'll be able to follow them over time. So that's at the beginning stages. And I think important to this too is at this point, it's only validated for adult responders. And we really need I would love to see a validation with adolescent responders, and seeing, do all of these questions work for an adolescent responder? Can they answer them, or do we need to make some adaptations that way? So those are things that are on our mind, but that need to happen.
Yeah, that's really interesting. Yeah, if efforts are put in place to look at this through the perspective of adolescents and how their perceptions of family health might be associated with other variables we care about also from the adolescent's perspective, that could be really, really rich. But what I am excited about with this measure too is this very kind of psychometric expansion process where if I look at these items in these different family contexts and different family time periods, and how do these items operate within those contexts? That's really rich storytelling, actually. Even just these psychometric elements, like certain items weightier in certain contexts versus others? And I just think that in and of itself is really interesting and exciting to think about.
We'd love for you to jump in and start doing some of that work with us. So
invitation accepted.
We would, yeah, that's an invitation to all on the call. Like we were very much welcomed, as you can see, all the different investigators who've approached us from different countries with different languages and things like that. It only benefits the field to have more people involved. And then we do have quite a robust group that's looking at different stages of life, for instance, the 3-generation approach, the different types of households. And that's the only way we're really going to get that comprehensive picture. So we're open to everyone jumping in. And many of you, obviously, if you're attending this, you're already involved with family health work and across the life course probably and interested in that, but love specifically with the measure if you're interested to use the measure in your work.
Yeah, that's fantastic. I'm just noting something here in the chat, some positive feedback. Your wonderful study and findings. I'm curious to learn about future plans to turn it into policy change and who the partners might be for implementation. Any thoughts? I know there's some good slides there toward the end on those fronts a bit.
So I'll say one thing for if we're looking at like national policy level, we really need to get this into federal surveys so we can look at trends. And we probably can't, what we're hearing is we couldn't get like, even the short form is too long, but maybe we can get 1 or 2 or 3 items in, which is why one of our questions is if you could just select 3, what would be, and that's something we need to do a little bit more work on is, are there certain measures it's hard to say, how can you get 1 or 2 items that are a proxy for all these domains? Like it just won't quite work, but can we get something that's good enough that then we can start following and tracking, and then they can make policies that way. So that would be at the national level. But I think some of these things, just even that Jerica mentioned, depending on where you're working, there's policies that can be done in your workplace or in an educational setting that are important to pushing the work forward.
Yeah, for any of us who've been involved in measurement development to any extent, I think we all have so much empathy here, because you noted in this process, Ali, I think it was you said this, where that refinement process of selecting items, starting with like 70 and dropping that even down to like 40, how much pain that can cause to be like, oh, I don't want to drop any of those items. They're so good. They're so important. They tap into these little pieces here. So then, yeah, thinking about 1 item or even 3 items, it can be painful, but for these logistic reasons are sometimes so valuable. And thinking about these larger national data collection efforts, how fascinating would it be too to have these data sets collecting information on this front, which could be rolled up into geographic regions like a census tract or block? How does family health at those levels exert influence on the dynamics within that cluster of individuals? So I'm just thinking from a multi-level perspective now. I'm cognizant of time. I think we're right here at the end of the road. So I just want to thank our wonderful presenters once again for a great presentation. I want to thank everyone here who was able to join us. Please stay tuned for a recording of this webinar, which you, of course, are free to share with all of your colleagues and networks. Thanks again. Hope you have a great week.